Our second topic this morning is radiation oncology. Dr. Roger Hansen is a board-certified radiation oncologist. He's a native Utahn growing up in Salt Lake City. After a bachelor's degree from the University of Utah, he earned a medical degree from Creighton University School of Medicine, where he graduated with honors. Radiation oncology training took place at the University of Arizona Comprehensive Cancer Center, and he finished that in July of 2000. He currently is a partner at the Gamma West Cancer Services, where he specializes in brachytherapy. He has personally performed over 2,000 brachytherapy implants for prostate cancer and breast cancer, as well as a few other types of cancer. Dr. Hansen currently lives with his wife and 4 children in Farmington. He enjoys golf, boating, travel. One of his goals this year, which he talks about all the time, is he's going to do the marathon. So that's tomorrow, right? That's it. You okay? Yeah. Okay. All right. He's ready.
Thank you. Okay. Well, I appreciate this privilege to come and give you an update about the medical specialty of radiation oncology. Our group, Gamma West Cancer Services, started in Salt Lake City. We now have clinics in Ogden, Layton, Salt Lake City, Orem, and St. George. Our newest clinic is in Layton, Utah, and I'll tell you about that in just a minute. I have no financial disclosures, except that I still have student loans to pay, so if there's any of you willing to help out with that. Radiation oncology is one of the 3 branches of cancer therapy. These branches are surgery, radiation, and chemotherapy. Radiation oncology training is a 5-year residency after medical school. Well, today's radiation is not the same as it used to be. And I'm going to tell you about some modern radiation therapy treatments that are available today. Very old-fashioned radiation. The radiation beam was simply pointed at the cancer area. The patient was not immobilized. There was no way to verify that the patient was setting up correctly or that the area you were treating was actually being treated. The machine couldn't rotate around the patient. There was no way to shape the radiation beam, and how much dose you gave depended on just how red you got the skin. If the skin got really red, then he must have got a whole lot of radiation. Modern radiation is very different. Today's machines can actually detect patient movement, and if the patient moves, the machine will move along with it. Images are taken before and during radiation to verify that the proper site is treated. Radiation machines can rotate around the patient, and they can treat that patient from nearly any angle. And we do have ways nowadays to immobilize the patient. In this chart here, we show a vacuum bag. It's basically like a beanbag chair. After you suck all the air out of it, it molds into a hard cast of that patient's shape. And this can help position the patient exactly the same every day. We also have masks on the right-hand side. These are a stretchy, rubbery material that you pull over the patient's face. Holes open up so you can see through it and breathe through it. And after this mask dries, it's hard and cast-like, and it just molds to the patient's head. And then you can kind of bolt this down to the table and keep their head from moving. Modern radiation treatments, the beams that treat a patient are custom shaped for that patient. So this picture shows a radiation beam coming out of the top of a machine. And then as the radiation passes through the machine, it is shaped. The part of the machine that does the shaping is called a multi-leaf collimator. These are thick lead leaves that can move back and forth, and we can shape the radiation any way we want. So the radiation comes out of this machine and it gets shaped. And not only can we change the shape of the radiation beams, but we can change the intensity of the radiation beam from one side of the field to the other. There's parts of the radiation beam we can make more intense, and there's parts of the beam that we can block off and make less intense. This kind of radiation is pretty standard now. I think most every cancer center in Utah will deliver this type of radiation. It's called intensity modulated radiation therapy, or IMRT. There is some newer types of radiation that are currently available in our market. One I'd like to talk to you about now is called tomotherapy. For those of you that have patients from Davis County, that's Layton, Farmington, Bountiful. This is the type of radiation that would serve your patients. The Tomotherapy Cancer Center is available at the new cancer center at Davis Hospital. This is the first cancer center that Davis County has ever had, and it's the only cancer center there. Tomotherapy looks like a CT scanner because it is a CT scanner. A patient would lay on the treatment couch and they get a CT scan of the area treated every day. This CT scan helps make sure that the patient is lining up correctly on the machine and that we are treating the correct part of the body. This tomotherapy machine delivers radiation continuously around the patient from every single angle. So any angle of 360 degrees, the radiation can come in at. And this combination of being able to shape the beam with a multi-leaf collimator to treat from any of 360 degrees and also to change the intensity of the radiation beam, this allows us to shape the radiation and get dose distributions around a complex tumor that we never could do before. This type of radiation is called image-guided radiation therapy. All right, just please give a click here. I'm going to walk you through a typical treatment session for tomotherapy. What happens first is the patient is laid on the radiation table called a treatment couch. A quick three-dimensional CT scan is obtained of the part of the body that we plan on treating. So this is a CT scan just like they would get at the hospital. After this three-dimensional CT scan is obtained, it is compared to a CT scan that was obtained for this patient's radiation treatment plan. So on the left of the picture shows the radiation or the CT scan that we planned radiation off of. These two images are overlaid automatically by the system, and if a shift is made, in this case it goes up and then over, the treatment couch that the patient lays on will also move up and over to match the CT scans. And after you've verified that the patient is now correctly set up, then the treatment will begin. So the patient is automatically moved into the donut of the CT scanner and the radiation treatment will happen. Now, the radiation treatment is illustrated by the red line, and you can see that at some points the red line is thick and full, and at other points the red line is very thin and narrow. And this radiation beam is being treated or shaped and modulated as it goes into the patient. And at every angle it's slightly different than another angle. What shapes the radiation beam is this multi-leaf collimator. And you can see the leaves of that collimator are moving in order to shape the radiation beam and let it through to treat the patient. What I'm going to show now is a head and neck treatment plan. Now, on the left is a CAT scan. Outlined in red is the patient's tumor volume. The green over on the side is the parotid gland, and purple or blue right here would be the patient's spinal cord. And what you can see is the radiation covering the target volume, sparing the parotid gland and sparing the spinal cord. And being able to do this with radiation to protect that parotid gland especially is very important in head and neck cancer. If you destroy the parotid gland, the patient will lose saliva. They cannot eat. Their teeth will rot. It makes it trouble to speak and swallow. So being able to protect that parotid is a very important goal in radiation treatments. Can you advance to the next slide? Maybe I can do it here. Another type of radiation that we have is called cyberknife. This type of radiation is called radiosurgery. A cyberknife is the world's only radiosurgery system that can treat anywhere in the body. Now, standard radiation treatments, as you probably know, involve the patient going into a cancer center and having a radiation treatment once a day, Monday through Friday, for many weeks in a row, generally 6 to 8 weeks in a row. Radiosurgery is different than that. Radiosurgery treats with very large radiation doses and only gives a few of them. An entire course of radiation would generally be given in just 1 up to 5 treatments. We call these radiation treatments fractions. So this shows a radiosurgery treatment for a tumor in the head and neck. You can see, radiation beams come in from everywhere, and they just focus in on where that tumor is and can blast it away in just one big shot. The cyberknife has software, like we talked about before, that can track and continuously adjust the treatment for any patient movement. And if you have a tumor in the lung, you can't stop the patient from breathing for 15 minutes while you give the radiation. But as you breathe and as the tumor moves in the lung, this machine can track along with that and continuously hit it. When we have a tumor in the head and neck, or even some benign diseases, trigeminal neuralgia and meningiomas, other benign diseases in the brain, we can treat these with a cyberknife. There is no rigid head frame that's required. You don't have to screw a halo into the skull that would bolt to the table. You can just make one of those masks that I showed earlier, and that can immobilize the patient. This cyberknife has unlimited ability to treat anywhere in the body. Another type of radiation, what I do most of the time, is brachytherapy. Now, this picture here on the left shows a man having a brachytherapy treatment for prostate cancer. You can see some implant needles placed through the perineum. The rectum is on the bottom, the man's scrotum is up here. An ultrasound probe is placed in the rectum, and that helps guide these needles up into his prostate. There's a special template that the needles are placed through. This is the same patient, what he looks like on an X-ray. Now this looks, maybe a little traumatic and not anything you'd want to go through, but I'm telling you, this is a much gentler thing, poking in some needles, than cutting through tissues like would happen with a prostatectomy. These are some of the images for radiation treatment planning. On the left, you can see a three-dimensional reconstruction of this man's anatomy. His rectum's on the bottom, his prostate is right here, and these are a bunch of implant needles that are poking through his prostate. And then up here on the top is part of his bladder. Now the small dots inside of these needles are positions that the radiation source is going to go to. On the left, it shows the same picture, the same patient's anatomy, but we turned the needles off. You just don't see the needles anymore. The purple cloud around this man's prostate represents the radiation dose that he is getting from his brachytherapy treatment. You can see the entire prostate is covered, along with a small safety margin to the outside in case any cancer has escaped out of his prostate. Now this purple cloud, we can make that shape anything we want. We can make it big. We can also pull it in tighter against the prostate if we want. If we want to push the radiation out further, then we keep the radiation longer at some of these outside positions, and the radiation will spread out. If we want to pull the radiation away from something, like we might do down by the rectum, then we just keep the radiation source shorter at those positions and the radiation will pull away from the rectum. But brachytherapy is a remarkable technology for delivering a very high dose to the prostate without having to penetrate through all the normal tissues. These external beam treatments that I've talked about they're very good, but they still have to go into the body from the outside. And as the radiation penetrates in, it will have to go through whatever normal tissues are there. That's the advantage of brachytherapy, though. We can bypass those normal tissues and put the radiation right inside the prostate and treat from the inside out. This is how treatments are administered. A patient would lay on his bed. A small machine with radiation in it comes in next to his bed. Tubes from the machine hook onto those implant needles poking out between his legs. We push a button on our machine and a radiation source travels back and forth in those needles. So the radiation machine is shown on the left, and the radiation source is that small radioactive seed right there that's welded on the end of a cable. So here's the needle in the prostate, here's a penny, and that's how big the radiation is right there. It's very small. It's smaller than a grain of rice. This radiation seed will be sent into the needles. He'll have a quick radiation treatment that takes 10 minutes. The radiation is then removed, and he's unhooked from that machine. So this is a different type of radiation or a different type of brachytherapy than what some of you may be familiar with. Brachytherapy started as a treatment that put small radioactive seeds in the prostate and left them there permanently. So that's called a permanent radioactive implant. Nowadays, though, most brachytherapy implants are temporary. Temporary implants have a number of advantages for a patient. Number one is we remove the radiation out of him when we're done, so when he goes home, he's not radioactive around his family. He doesn't have to worry about being around his grandkids or anybody pregnant, which is something that you have to worry about when you have radiation that's permanent. Another advantage to an implant that's temporary is side effects go away very quickly. Side effects are generally just a couple weeks long compared to months and months and months long like you would have if an implant was permanent. You can, if you remember back to those pictures, if you just remember your anatomy, the urethra that drains out from the bladder goes right exactly through the middle of the prostate. And if you blast away at the prostate, you're going to irritate that urethra. So a man is going to have some temporary urinary irritation, but it's better to have a couple weeks of that irritation compared to 9 to 12 months. And that's the difference in side effects between an implant that's temporary and an implant that's permanent. Another advantage to temporary implants is that it's a stronger type of radiation that can reach further around the prostate and treat with a better safety margin. So what I've tried to help you understand is that radiation is not one size fits all. We have many different radiation modalities, and I want you to have confidence that when you send your patient to a radiation oncologist, that we are going to pick what's appropriate for that patient, what would work the best, what would be safest, and what would do the best job at giving this patient a chance for cure. There is no reason that a cancer patient needs to travel out of state or to a large university center for best cancer care. In fact, much of the technology that I've mentioned in these slides isn't even available yet at our university. And even if the time comes that it is available up there, we will have experience, many years worth of experience in using this technology that they will just be learning. And as great as technology is, it's every bit as important that the doctors using the technology know how to do it. So I just wanted to put a plug in for your local doctors. Your local doctors can do every bit as good a job as somebody somewhere else. Now I'd like to review a prostate cancer case with you. This gentleman here worked with my dad at Unisys, or now L3 Communications, He presented back in August of 2004. He was a healthy 62-year-old guy. When he went into his primary care physician, his PSA blood test was found to be almost 44. So as all of you know, that's very elevated. What PSA should be is about 4 or less. To be 44 is very abnormal. He had a biopsy by his urologist, and nearly every single needle core was completely replaced with a high-grade cancer. The grades of prostate cancer, how aggressive it looks on the microscope, are called the Gleason score. Scores go from 2 up to 10, and this guy had a grade of 8. He had bulky, palpable disease on a digital rectal exam. And when we did some staging imaging to look for spread, we found 2 very large lymph node masses in his pelvis. One was 4 centimeters and one was 5. So, he already had obvious spread of his cancer into his pelvis. I asked his urologist to do surgery and remove these large lymph node masses. And then afterwards, we treated his prostate cancer with a combination radiation treatment. So he didn't have surgery that removed his prostate. He only had surgery that removed the big lymph nodes. The prostate cancer treatment was treated with medicines to block the testosterone hormone. Testosterone, as you probably know, will feed prostate cancer and help it to grow. So we blocked the hormone. Then we did wide field external beam radiation, with IMRT, that targeted the prostate plus the rest of his pelvic lymph nodes. And then afterwards he had a brachytherapy implant like I showed previously. This guy came to see me last month in follow-up. His PSA remains undetectable, really. It was 0.03. He has had no degree of bowel or bladder irritation. He has no incontinence of any kind. He has not had return of sexual function. That has been a side effect of his cancer treatment, but this is not a big priority to him. He was not very sexually active in the first place. This is a graph of his PSA history. Now, this is a very powerful image of his cure. You can see the PSA just skyrocketing in the years before his diagnosis, but ever since treatment, it's right there along the 0 line. He's off of all therapy, he's many years out from treatment, and he's cured. And, that's a remarkable outcome. Now, another case, this is a very young man. This guy's age 47. He's younger than where they even recommend screening. They don't say to start screening until you're 50. He's an aircraft mechanic out at Hill Air Force Base. He presented back in 2004 as well. His PSA at the time was 5.2, so a little bit elevated. His digital rectal exam was normal. He had a biopsy that showed just a small amount of cancer in his prostate. The grade, unfortunately, though, was still kind of aggressive. It was a grade of 7 out of 10. And you think if this man had not been screened and looked at for prostate cancer, if you had waited 3 more years until he was 50, having a high-grade cancer like a 7, this little bit that he had now would not have been a little bit 3 years down the road. And we may have lost our chance to cure him. This guy's health history otherwise is pretty good. He has a mild case of MS. He has some cholesterol problems, and he's been undergoing therapy for anger management. His metastatic workup was negative, and he elected to have treatment with brachytherapy implants alone. He finished treatment back in 2004. I saw him in follow-up last month. His urinary function is exactly the same now, 6 years later, as it was before. He has occasional constipation, but he thinks it's more from his drugs that he takes, not the radiation treatment. And otherwise, he has normal bowel function. He does require erection drugs for sexual function, but, he is happy that things still work as long as he takes these medicines. And best of all, this guy also shows a cure. So this is his PSA history, clear on up through April of 2010. So some things that I'd like you to know about prostate cancer are that When you have early disease, you're likely to be cured no matter what you do. Surgery works great. Radiation works great. There's lots of good treatments for early prostate cancer. And it isn't so much, picking the best treatment. It's picking a treatment that will preserve the normal functions that you want preserved afterwards. And radiation is remarkable in that ability. And another thing I'd like you to know is that young patients can have radiation. Now, we have some really good surgeons around, and we're glad that they're here. They like to operate on young people. Young people can tolerate aggressive things. But just because you're young doesn't mean you have to have surgery. You could also have radiation, and you would have just as good of an outcome. Another thing to help you understand is that high-risk patients can still have brachytherapy. Now, brachytherapy is a very confined treatment. We're good at the prostate, and we treat with a little bit of a safety margin, but brachytherapy doesn't go clear far out into the pelvis. So we would never treat a high-risk patient with brachytherapy alone, but we do treat with a combination. They get external beams that cover a big wide area, and then we give a boost to the prostate with a brachytherapy implant. The most comprehensive cancer treatment a man could get for a high-risk prostate cancer is this combination of blocking hormones, then wide-field external beam radiation, and then a brachytherapy implant to where the main cancer is in the prostate. We're active in keeping track of the data on our patients and also presenting this data at medical meetings. Just a few months ago, we presented at the Western section of the American Urologic Association. I'm telling you, to have a group of radiation doctors go into the urology meeting and talk about brachytherapy, that's going into the lion's den for sure. Since 2001, we have treated 1,200 patients with high-dose rate brachytherapy as a single modality. If you look at the 284 patients who have higher risk features, again, you know that low-risk patients do well with everything. But if you look at higher-risk people who start to have a little bit of a nodule, or they've got a little higher grade of cancer on their biopsy, or a higher PSA, if you look at those people treated with brachytherapy, their 5-year overall survival is 100%. Nobody has died yet. Distant metastases-free survival, 98.8%. Hardly anybody ever ended up with metastatic disease. Biochemical recurrence, that means having their PSA blood test come back. That has developed in 7 patients out of 284 for a control rate there of 94%. These are excellent numbers for prostate cancer. The point here is that temporary brachytherapy or high-dose rate brachytherapy as a single modality provides excellent long-term control with very favorable toxicity. Patients can usually return to work within the week after their treatment is complete. They have no catheter, no pads. They're happy patients. Okay, now I have to hurry and just throw in this picture here. I'm going to talk for just 1 sec until my time runs out about breast cancer. This is not a breast cancer picture. This is me after running for 4 hours in the snow. I've since learned that if you're going to run in the wet snow, you got to put a Band-Aid on your nipples. But anyway, we have some remarkable breast cancer treatments. This is a brachytherapy treatment with a balloon. This is a brachytherapy treatment with catheters that are placed through the breast. These brachytherapy treatments are not for everyone. They do give the entire radiation treatment, though, in 1 week. Normal radiation takes almost 7 weeks after surgery. But if you have a small cancer and it hasn't spread anywhere, then you can have one of these brachytherapy treatments, this one with a balloon or this one with catheters, and you can have your whole radiation treatment given to that part of the breast where the cancer was, and you can be done with your treatment in a week. Anyway, I think my time's about up. If any of you have questions, I'm happy to do my best to answer them, or I can talk to you privately afterwards.
Any questions? If so, please hit your microphone. We'll appreciate it.
Are you seeing any new, any differences in impotence rates for the prostate cancer with the old, seed type brachytherapy versus the newer high dose stuff that you were showing?
The question is there a difference in protecting sexual function, whether you have a temporary implant or a permanent implant? The impotence or losing sexual function is about the same either way. So sexual side effects are not different. What is different, though, is improving urinary function a lot quicker with a temporary implant.
If you do have a couple of hot spots, metastatic prostate cancer, say on a bone scan, can you hit these isolated spots also for a cure, either with brachytherapy, depending on the location, or with external beam radiation?
We wouldn't use brachytherapy to go after anything that was metastatic. But external beam radiation certainly could be. When a guy has metastatic disease, he may only have one or two spots that show up on a bone scan, and you can certainly treat those, but in all likelihood, he has smaller amounts of cancer elsewhere as well that you just aren't seeing yet. And we would not tell the guy that this might cure you. If you have metastatic disease, especially to the bones, then it's very, very unlikely that you would cure him. You can do him good, you can relieve his pain, and you can extend his life, but the likelihood of cure is not great when it's in the bones.
What sort of follow-up do you have on the CyberKnife and the temporary brachy?
Temporary brachytherapy has been used extensively along the Wasatch Front for more than 10 years. We have hundreds and even thousands of patients. The data there is excellent. CyberKnife is brand new. CyberKnife is a treatment that's just, it's a few years old. There's some places that use it a little bit for prostate cancer, but the data is brand new. With any new treatment, it might seem good, but you like to see longer-term data before you use it in everybody. So we don't really recommend CyberKnife as a treatment compared to brachytherapy. Brachytherapy is more proven in that case.
Good luck tomorrow. Hey, Roger. Good luck tomorrow.